Assalamu alaikum. This lecture will be about postpartum hemorrhage. Lecture objectives: to know the definitions and different etiologies of primary postpartum hemorrhage, to recognize postpartum hemorrhage and to be able to both initiate and coordinate multidisciplinary plan of management, to focus on uterine invasion, diagnosis and management, to have a good knowledge about uterine rupture presentation, to know how to deal with retained placenta, definition, modalities of treatment. Definition of primary postpartum hemorrhage is a loss of 500 ml or more of blood from the genital tract within 24 hours of birth of a baby, or any loss of blood associated with signs and symptoms of hypovolemia. Maybe the patient أصلا تكون anemic، عشان كده less than 500 ml can be associated with symptoms of hypovolemia. Other definition, old definition, إنه at vaginal delivery 500 ml loss and cesarean section more than 1000 ml loss. This is regarding primary postpartum hemorrhage. Definition of secondary postpartum hemorrhage is abnormal bleeding from the genital tract or birth canal between 24 hours and up to 12 weeks postnatally. Most definitions of gestation, diabetes, gestation, hypertension up to 6 weeks, but in postpartum hemorrhage up to 12 weeks postnatally. That's the last definition. Complicate 5% of BPH, complicate 5% of deliveries. Postpartum hemorrhage is the leading cause of maternal mortality in low resources countries. Classification of BPH, either minor or major. Minor BPH is 500 to 1000 ml loss. Major BPH is a loss of more than 1000 ml of blood. Major BPH can be classified into moderate and severe. Moderate postpartum hemorrhage is loss of 1001 to 2000 ml, and severe postpartum hemorrhage is a loss of more than 2000 ml of blood. How can estimate this amount of blood? Subjective assessment of blood loss is useless due to inter-observer bias and inter-observer bias also. So we use quantified blood loss. Create a list of dry weights for delivery items that may be blood sucked. Example, surgical gauze should be weighted and to be known. Begin quantified blood loss immediately after birth of the infant. At the beginning of third stage of labor, we start quantified blood loss because before the infant birth, the fluid mainly either amniotic fluid or urine. Using calibrated and robotic strip or suction canister. بيكون في collection of fluid at this strip or suction. These strips and suctions are known volume numbered in ml. Any blood loss will be collected in drip or suction can be calculated easily. Subtract the pre-placenta fluid volume from the post-placenta fluid volume. Weight all blood sucked materials and clots to determine cumulative volume. By this we calculate quantified blood loss and apply this according to the definition of BPH, either minor or major postpartum hemorrhage. Risk factors for BPH: intrapartum risk factor, induction of labor, prolonged first, second or third stage of labor, precipitated labor. Active phase will be less than 3 hours. This is too short period. Associated with many complications, one of them is postpartum hemorrhage. Vaginal operative delivery, ventouse or forceps, mainly male forceps, it's traumatic to mother mainly, and ventouse traumatic to the baby. Cesarean delivery. Antenatal risk factor for BPH is previous history of postpartum hemorrhage, obesity, gram multiplicity due to atonia, antepartum hemorrhage. ABH is a risk factor for BPH. Overextension of the uterus, either by polyhydramnios, microscopic baby, or multiple pregnancies. Uterine abnormalities, example anatomical or fibroid. Solar placenta, one of the causes of antepartum hemorrhage. Anemia and coagulability, either congenital or acquired. Potential sequelae of BPH: orthostatic hypotension, anemia, and fatigue make breastfeeding and maternal care of the newborn more difficult. BPH can increase the risk of postpartum depression and post-traumatic stress disorder. Blood transfusion may be necessary, and associated risks include infection and transfusion reaction. In severe cases, DIC should be anticipated. Hemorrhagic shock may be lead to Sheehan syndrome, which is one of the causes of panhypopituitarism. Posterior pituitary ischemia with delay or failure of lactation. بتكون هي panhypopituitarism. All the pituitary hormones will be dropped, but first diagnosed by failure of lactation. Minimizing risk of postpartum hemorrhage. It's important to discuss options for prevention of postpartum hemorrhage with mother antenatally when anticipated. Treating antenatal anemia, correction of hemoglobin, reducing blood loss at delivery by active management of third stage of labor. Etiology. The most common etiology of primary BPH is uterine atony, followed by genital tract trauma. It's summarized in a mnemonic of 4 T's. First, tone is the most common cause, then trauma, tissue, and thrombin. The major etiological factors associated with secondary BPH are then placental fragments and endometritis infection. Mainly in this lecture, we talk about primary postpartum hemorrhage. For primary postpartum hemorrhage, here 4 T's, with secondary postpartum hemorrhage whole infection and retained placental tissue. Tone almost 70%, trauma 20%, contain lacerations, hematomas, uterine inversion, and uterine rupture. Tissue either retained tissue or invasive placenta اللي هي morbid placenta accounts for 10%, and thrombin coagulopathy either acquired or congenital account for less than 1%. First, we talk about resuscitation. Major postpartum hemorrhage. The major resuscitation measures use an interdisciplinary team approach, including anesthesia, laboratory, nursing, surgery, and blood bank staff, also allows the theater. As part of an initial management of this emergency, providers should perform a primary maternal survey and institute care to support circulation, airway, and breathing. Circulation prior to airway and breathing. First, insert 2 large bore IV cannulae, either size 16 or 14. Transfuse blood as soon as possible, if clinically required, until blood is available. Infuse fluid until 3.5 liters of warm fluid. Blood if immediate transfusion is indicated. Emergency O negative blood, and switch to group specific RBCs as soon as feasible. Blood will be prepared and cross-matched. Transfuse fluid, maximum 3.5 liters of warm fluid. If blood transfusion indicated immediately, start with O negative blood until cross-matched blood be ready. At this time, with insertion of IV cannula, draw 20 ml of blood for diagnostic test. Include blood group and cross-match 4 units of blood, complete blood count, coagulation screen, urine electrolyte, and hold a blood tube which is with red top for clot evaluation. We'll send this investigation for laboratory and hold 5 ml beside the bed for coagulation evaluation. Maintain patency of airway and administer supplemental oxygen to maintain oxygen saturation more than 95%. Examination determines the etiology of the hemorrhage, often performing uterine massage. Place a Foley catheter to empty the bladder and maintain uterine tone. All of these will be at the same time, so it will be managed in a team. So, call for help first, it's an obstetric emergency. Call for senior obstetrician, midwife, other additional staff, anesthetist, blood bank, alert laboratory and hematologist. Inform the theater and alert the blood bank. The team leader will organize the group, and anyone will be responsible for specific mission. Mass transfusion protocols that recommend infusion of fresh frozen plasma and platelets whenever large amount of packed RBCs are needed. Will act using mass transfusion protocol, the local one. according to hospital guidelines. If hemorrhage continue after 4 units of red blood cell and hemostatic tests are unavailable, administer 4 units of fresh frozen plasma and 1 unit of platelet. There is different mass transfusion protocols. One of them is 1-1 from the start. From the first unit of blood, will transfuse plasma 1 unit and 1 ball of platelet. Other protocols from the fourth unit, as mentioned here, 4 units of fresh frozen plasma and 1 unit of platelet. Other protocol from the 6th unit of blood, according to local guideline. But make sure in obstetric hemorrhage, we transfuse blood and blood product to prevent coagulopathy. Hypothermia worsen coagulopathy and increase peripheral vasoconstriction, which might decrease effectiveness of drug administered via peripheral IV. Hypothermia either from the weather or from blood transfusion. The blood will be stored at a low temperature, and when transfused rapidly, the patient will develop hypothermia. So, warm blanket and the fluid warmer can be used. This is a general management of postpartum hemorrhage. Specific management strategies will start with atonia, which is half non-pharmacological management, medical and surgical treatment. Then trauma, we'll talk about uterine rupture and uterine inversion. Regarding tissue, we'll talk about retained placenta, and the last we'll talk about thrombin as the least cause of postpartum hemorrhage. Uterine atony can be managed pharmacologically or by combination of pharmacological and surgical interventions. If the placenta is thought to be complete, after dealing with the placenta, we examine the placenta to be either complete or there is missed botulism. If the placenta is complete, the first maneuver to reduce blood is fundal uterine massage. Administered uterotonics is a type of drugs cause uterine contraction. First, oxytocin is ineffective as first line treatment. Oxytocin produced from the hypothalamus and stored at posterior pituitary gland. It's called uterine contraction. So it's the first line treatment for postpartum hemorrhage. Second line agent used as uterotonic might be based according to women's risk factors. Second line uterotonic: first, methyl ergonovine, وهو ergometrin or methyl ergometrin, avoided in hypertensive disorders of pregnancy, including chronic hypertension. Ergometrin causes smooth muscle vasoconstriction and will raise the blood pressure. Misoprostol, which is prostaglandin E1 analog, caution in patients with cardiovascular disease. The third is carboprostol, which is methyl prostaglandin F2 alpha analog, have relative contraindication in patients with asthma or significant renal, hepatic, or cardiac disease. Only absolute contraindication is allergy to carboprostol. After uterine massage and uterotonic, bimanual compression of the uterus may also need to perform at this stage. This decreases blood loss partly because of the fact that it puts uterine arteries under tension. This image illustrates the bimanual uterine compression. The dominant hand inserts into vagina like a fist in anterior vaginal fornix, and the non-dominant hand abdominally compresses the fundus in between. As the uterine arteries will be kinked by this action, the blood supply will be decreased and blood loss also. In addition to uterotonic, drugs that promote coagulation can be administered, as tranexamic acid, which is antifibrinolytic, will decrease the degradation of fibrin and fibrinogen. Also can use recombinant factor 7A. If these pharmacological and basic surgical steps have not achieved hemostasis, the uterus can be packed by either a traditional technique using gauze or using balloon insufflation. Uterine tamponade devices can be used to treat postpartum hemorrhage due to uterine atony or minimize uterine bleeding while definitive treatment or transport is arranged. This demonstrates uterine tamponade balloon catheter. This is the first surgical step. For research setting, use this tamponade as a test. will be inserted the rubber catheter, sterile rubber catheter inserted intrauterine and inflated with fluid up to 500 ml will be inflated to overcome the venous and arterial blood pressure of the spinal arteries and include these vessels. This is called tamponade test. If vaginal bleeding stop or decrease, it's called positive test and will be maintained intrauterine for 24 hours. If vaginal bleeding is continuing, it's called negative test and patient will be shifted to the theater. Examination of the genital tract needs to be performed with adequate lighting and patient anesthesia. This usually means examination under anesthesia, regional or general anesthesia. Examination under anesthesia should include examination of the vagina, cervix, and in case of continued bleeding, exploration of the uterine cavity. Digitally to identify and remove any retained fragments of the placenta. Examination from the vulva, episiotomy, and vaginal laceration, vaginal wall, cervical, and uterine cavity. Uterine exploration also will allow detection of ruptured or partial uterine inversion during this EUA examination under anesthesia. Hypotension or shock out of proportion to the amount of blood loss raises suspicion for concealed hematomas, example broad ligament hematoma, or uterine rupture and uterine inversion. If these steps fail, the patient will require laparotomy. Surgical options. First line surgical management هو uterine balloon tamponade. اتكلمنا عن tamponade test. Second هو hemostatic sutures, example Blanche. The third is stepwise uterine devascularization and internal iliac artery ligation. In stepwise uterine devascularization, it starts with unilateral uterine artery ligation. If failed, we'll do bilateral uterine artery ligation. If failed, we'll do unilateral ovarian artery ligation. The fundus of the uterus have anastomosis with the ovarian artery. If failed, bilateral ovarian artery ligation, and if failed, we'll do internal iliac artery ligation. The uterine artery is a branch of anterior division of internal iliac artery ligation. If there is available interventional radiologist, selective arterial occlusion or embolization will be an option. If all of these failed, which will preserve the fertility for the woman, if all of these failed, hysterectomy is an option as life-saving procedure. In a summary, uterine atony are non-pharmacological by uterine massage and by manual uterine compression. Pharmacological by uterotonics. First line is oxytocin. Second line either ergometry, misoprostol, or carboplast. Surgical management first by tamponade. Second by hemostatic sutures, example Blanche. Then stepwise uterine devascularization. If failed or if there is interventional radiologist available, selective arterial occlusion or embolization. The last is hysterectomy. This is uterine atony. Uterine rupture. Uterine rupture is a disruption in the continuity of the uterine muscle extending to and involving the uterine serosa beyond 28 weeks of pregnancy. If the uterine serosa is intact, this is called uterine dehiscence. Any disruption of continuity before the 28 weeks is called uterine perforation, not uterine rupture. Clinically significant uterine rupture complicated by 8% of labor after cesarean section deliveries. 0.8%. The risk is significantly increased in women with previous classical uterine incision or myomectomy. Classical uterine incision is بتكون في الupper uterine segment and have a higher risk of rupture uterus. Presentation of uterine rupture. During labor, the first sign of uterine rupture is typically fetal heart rate change, such as fetal bradycardia. Or the first sign, fetal heart rate change. Other signs and symptoms include vaginal bleeding, known cause of postpartum hemorrhage, abdominal tenderness, increase in abdominal girth, loss of uterine contraction due to loss of uterine integrity. Uterine contraction will be ceased. Elevation of the presenting part, fetal part station during vaginal delivery will be lost. Maternal tachycardia and circulatory collapse. In this image, there is scar adhesions, first state, there is disruption, but cirrhosis will be intact, and the fetus will be in utero, still intrauterine. The placenta will start to be separated. If it's not diagnosed and not delivered, will be complicated by complete placental separation and will be floating abdomen. Even the fetus will be out of the uterine cavity, will be abdomen floating. This baby is bluish, indicates there is cyanosis and will be complicated by stillbirth. Uterine rupture for urgent laparotomy and delivery of the fetus. Repair of the site of uterine rupture if it's repairable. If not, it will be for hysterectomy to control bleeding. Uterine inversion. The uterus is turned inside out, partially or completely. The uterine inversion is rare, incidence is 1 in 10,000 pregnancies. This image represents how uterine inversion can occur. The uterus inverted inside out. This is abdominal side and this is endometrial side. Risk factors for uterine inversion is fundal placenta and morbid lateral placenta during third stage of labor. The cord traction in a morbid lateral placenta can cause uterine inversion. Short umbilical cord tuberculosis will inhibit uterine contraction and the uterus will be easy to be inverted. Manual removal of the placenta and associated mainly with collagen disease like Ehlers-Danlos syndrome. Types of uterine inversion: first degree, second degree, third, and in some reference it's 4 degrees. First degree is dimpling of the fundus, which still remain above the internal os. Second stage, the fundus pass through the cervix but lie inside the vagina, cross the internal os but inside the vagina. Third degree or complete uterine inversion, the endometrium, with or without the attached placenta, is visible outside the vulva. يعني في الفيرست degree اللاند مارك هو internal os، في السكند degree هو بتكون inside the vagina، في الثird degree بتكون outside the vulva. Cervix and part of the vagina may also be involved in the process. Can occur after separation of the placenta or before، يعني either during third stage or after third stage of labor. This is first degree. This is first degree uterine inversion, only dimpling, and not reach the level of internal os. In second degree, it reached the internal os. During the third degree, it reached the vagina. Fourth degree is out the vulva. Dangers. Why uterine inversion is important? Uterine inversion can cause neurogenic shock. Neurogenic shock origin due to tension on the IPL, infundibulopelvic ligament, and pressure on the ovaries as it's compressed through the cervical ring. Also, neurogenic shock can be occurred due to peritoneal irritation. Diagnosis: symptoms: patient complain of acute lower abdominal pain. Signs: there is varying degree of shock, but it's a constant feature. Neurogenic shock. Abdomen examination is cupping or dimpling of the fundal surface. Pear-shaped mass protrude outside the vulva with a broad end pointing downward and looking reddish purple in color. Abdomen examination بيكون في cupping or dimpling. Vagina examination لو عملت بعد inspection بتلقى فيه pear-shaped mass protrude outside the vagina. On inspection, the inverted uterus may be in the vaginal vault or may protrude from the vulva. Placenta may still be attached and it should be left in place until reduction of the inverted uterus, because the placenta separation at this time with lax uterus can cause profuse postpartum hemorrhage. There are several methods of reduction. Manual reduction, called Johnson method, involves grasping the protruded fundus with palm of the hand with fingers directed towards the posterior fornix. This is Johnson method. The fingers grasp the protruded part by the palm. This is palm and this is protruded part. The fingers directed against posterior vaginal fornix. This is posterior vaginal fornix, and this is anterior one. This is endometrial line, and this is the uterine fundus. The uterus is returned to position by lifting it up through the pelvis and into abdomen with steady pressure towards the umbilicus. After the uterus is reversed, uterotonic agents should be administered to promote uterine tone and prevent recurrence. After replacement, the doctor will maintain his hand inside the uterine cavity and start uterotonic to maintain uterine contraction to prevent recurrence. If initial attempts to replace the uterus have failed or cervical contraction ring develop, uterotonics tocolytic, example terbutaline and nitroglycerin or general anesthesia, may allow sufficient uterine relaxation for manipulation. Can be repeated this manual reduction under anesthesia or after using tocolysis. Other technique called Sylvius hydrostatic technique might be attempted. The vagina is filled with warm saline while being blocked as introitus with attendants or Dr. Fist. The introitus will be blocked by the fist and infusion of the 4 to 5 liters of warm saline sufficient to balloon the vagina and reverse the uterine inversion. This is called hydrostatic technique. If these techniques failed, laparotomy is indicated and because the uterus will be ischemic from the obstruction of the blood supply. This is trauma regarding uterine rupture and uterine inversion as an example. Tissue return product, example placenta or placental fragment and blood clots. Prevent uterine from contracting enough to achieve optimal tone. Even full bladder can prevent the uterine contraction and achieve the optimal tone. During the third stage of labor, we handle the placenta using branded maneuver. In branded maneuver, firm traction on the umbilical cord with one hand, while the other hand applies separate counter pressure to prevent uterine inversion. Typically achieves the placental delivery. This is the branded maneuver. One hand with gentle traction and the other hand separate pressure, not fundal. It's separate pressure to guard against uterine inversion. Retained placenta, defined as failure of the placenta to deliver within 30 minutes after birth. The regarding active management, لأنه physiological management 60 minutes. Retained placenta occur in 3% of vaginal deliveries. Either manually remove the placenta, there is cleavage plane between endometrium and the placenta. This plane cannot be identified or not well developed. This is sign of mobilizing placenta and prepare for surgical removal of the placenta. So the placenta removal either spontaneous or manually or surgically. This image represents manual removal of the placenta. Conservative management option for retained placenta include partial removal of the placenta, arterial embolization, methotrexate and or watchful waiting. The retained placenta can be observed but increase the risk of infection and postpartum hemorrhage, secondary postpartum hemorrhage. Arterial embolization if intervention radiologist available. If not applicable, partial removal of placenta and methotrexate treatment. Methotrexate is cytotoxic كان كلامنا عنه في الGTD gestational trophoblastic disease. Women treated for retained placenta must be monitored for late cycle, including infection and late postpartum hemorrhage, secondary postpartum hemorrhage. Thrombin. Coagulation disorder is a rare cause of PPH. Coagulation defect may cause either congenital or acquired. Coagulation can occur from hemodilution by IV fluid or by transfusion of only packed RBCs without fresh frozen plasma and platelet in a massive transfusion protocol. Don't miss hypothermia as a cause of coagulopathy. Coagulopathy should be suspected in women who have not benefited from usual measures to treat BPH and are not forming. Even the blood loss will not clot it, or are bleeding from puncture site. Obstetric conditions that can cause DIC, preeclampsia, severe features, specifically HELP, HELP syndrome, stand for hemolysis, elevated liver enzymes, and low platelet. This thrombocytopenia can be cause of BPH. Amniotic fluid embolism, sepsis, placental abruption, massive postpartum hemorrhage, and prolonged retention of dead fetus. In intrauterine fetal death, there is 10% risk of DIC development. Management of coagulopathy consists of treating underlying disease according to the cause, evaluating coagulation status, and replacing appropriate blood component, and supporting intravascular volume. This is management of coagulopathy. A supportive management. Tranexamic acid, which is antifibrinolytic, decrease breakdown of fibrin and fibrinogen, may reduce complications from hemorrhage, and could be considered as adjuvant therapy to uterotonic agents. Post-stabilization care and debriefing. The patient will be shifted to HDU, high dependency unit, or intensive care unit. Postpartum hemorrhage is a frightening effect. 9% of cases complicated by post-traumatic stress disorder due to traumatic childbirth. In addition to support of healthcare team, women with acute stress symptoms benefit from cognitive behavioral therapy. And don't forget documentation in obstetric emergencies. Thank you.